Thank you very much, Professor Musa and Professor Clevien. Dear colleagues, first of all, let me thank you, the organizing committee, for the kind invitation to talk about DCDs. Well, I guess that there is a need for organs of liver organs in terms of necessity. We can see that in the United States right now there are around more than 100,000 people waiting for a liver. And in Spain, although we have such a high rate of donation, the causes of dying related with the liver in a year maybe increase up to 10,000, more than 10,000 people. Nevertheless, the number of liver transplants that we perform in Spain are a steady number, around 1,000. And if you see what happens in a given year, we can see that there are included around 2,000 people in order to be transplanted, ended up transplanting almost 1,000, and there are still in the need quite a number, such as 700 people waiting for a liver. So I think we need to maximize the donor pool. We need to expand the donor pool by including marginal donors, and within them, I think DCD would be a very good alternative. You all know this classification, master classification. Most of you are aware that there are two main types that are used during DCD retrieval. One is called the uncontrolled ones, which are those CPR where cardiopulmonary resuscitation maneuvers are unsuccessful. They are very frequent, see you later. And type 3, which are the so-called control, where are those in the ICU, where you remove the ventilatory support and you are waiting for the cardiac arrest. The first type is type 2. DCDs are very frequent. At least 22,000 people each year who die of cardiac arrest outside of a hospital could be a potential donor. If only a quarter of these patients, of these individuals, turn out to be a donor, you may be able to fix all the necessities of a country like the United States. The problem with DCD is the preservation injury. Not only the cold ischemia that will suffer, plus the rewarming, plus the reperfusion injury, but also the pre-preservation, that is the warm ischemia that is suffering during the period of cardiac arrest. And we know that during this period, there is a depletion of intracellular ATP going to anaerobic metabolism that goes to intracellular acidosis. We lost the sodium-potassium pump integrity that will end up in the loss of the membrane integrity, getting into inflammation, degradation, and cell death. Well, what happens then? Goes to the clinical setting, and then you will find that out of this type of livers, there is an increased incidence of primary non-function, increased incidence of problems with the artery, mainly thrombosis, and the Achilles heel in this type of donors and in this type of livers, which is biliary complications, mostly related to preservation injury, and they becoming clinically evident as what is called ischemic cholangiopathy. This is a typical image of a ischemic cholangiopathy, where you can see the biliary tree just 10 days after transplantation. Then after 1 month, you see a little bit of rigidity of the whole tree, biliary tree, and then after 3 months, you get the stenotic of the bifurcation. Well, the problem with any type of DCDs, either type 3 or type 2, but just here is a sample of type 3, is the warm ischemia time. And this is very variable. It depends on the minutes that the patient turns out to stop the heart, takes the time to the heart to stop. And although they try to keep, in order to get the liver, this what they call the warm functional time to warm ischemia to 30 minutes, this is very variable, and it turned out to have all these problems, which in the different series around the world suggest a biliary complication that goes up to 55%. Only the King's College group has been able to achieve a very relatively low incidence of these complications, 9%. So I guess the idea is to maintain these organs. How to maintain these organs in order to avoid as much ischemia and much harm, injury to the liver in time to take. I'm talking mostly about getting the liver out, because out of the kidney there are many alternatives, such as perfusion, abdominal compression, hypothermic recirculation. However, if we are going to retrieve the liver, then I guess normothermic recirculation at the time of the death is the best idea. Nevertheless, normothermic recirculation needs to be more efficient, needs to be more effective, and I think it needs to be combined with advanced forms of organ maintenance exciton, and we'll see these. We know normothermic recirculation works. This is experimental research that we performed previously. We can see that only by the use of 1 hour of normothermic regional perfusion, or NECMO, however you want to call it, after 90 minutes of cardiac arrest, the animals are able to survive in 83%. But not only survive, but the quality of the livers are also very good. When you put this into the clinical setting, there are different steps that I'm not going to go through them because it would take too long, but it is important, the death declaration in Spain, we have to wait at least for 5 minutes before you do anything into this potential donor. But after that, we are able to cannulate and to place a balloon catheter into the thoracic aorta in order to avoid the perfusion of the lungs, in order to be able to take them out. By doing so, we place this individual in what we call normothermic recirculation, which allow us to maintain the organ, not only the liver, but the kidneys too, in order to be able to get the permissions. If the permission is not given by the family, then everything is stopped. The idea is that fulfill the criteria that we have already published, in which the cardiac arrest has to be less than 15 minutes and hopefully witness. The advanced cardiorespiratory support should be lower than 150 minutes. This taken into account, including the time that is taken to the medical ambulance to take this individual to the emergency department. And the NECMO, or normothermic regional perfusion, has to be lower than 4 hours. If you do that, and you have a characteristic of the donor with a very good pump blood flows over 2 liters, and the transaminase levels at the end of the procedure are no more than 4 times the normal level, then we will be having a reasonable good liver to be transplanted. The criteria of our group, as you can see, is what I just said. With hematocrit, it has to be over 20%. If it needs, we put blood into the machine. These are our late results. We are now, this is our first 34 patients, and we conclude that the survival was safe in a scenario, of course, of donor scarcity. However, as you can see, the results are, the graft survival is significantly lower in those submitted to a DCD transplant when compared to deceased donor. Anyway, this associated to a low, and this is interesting, a low incidence of ischemic angiopathy, only 3 cases, 8% of them, and 1 case of anastomotic stricture. That gives us an overall rate of biliary complications of 12%. 12%, which compares favorably with all the rest of the experience with type 3 donors in the world. The problem is that out of 400 protocol activation, we have only been able to cannulate 290. Finally, 145 have been considered organ donors, and from them we have only used 34 livers. Nevertheless, we have also used kidneys, and out of those 187 kidneys obtained from these very same donors, we have been able to see, this courtesy of my friend Dr. Oppenheimer, has shown us that the graft survival is virtually identical to that kidneys obtained from deceased donors. Well, recently, a group of UK, which one of the co-chairs is one of the authors, are introducing normothermic regional perfusion in type 3 DCD donors. And the results are very promising, although not easy to obtain. Out of 16 individuals that were able to be placed into normothermic regional perfusion, they were able to obtain a significant number of organs. But the idea, as you can see here, is to do that only when, to get the liver only when the functional warm ischemia is under 30 minutes. And they consider functional warm ischemia when the systolic pressure is under 50 millimeters of mercury and the saturation of oxygen is under 70%. Well, and similar to our group, the normothermic regional perfusion total time is maintained within 3 hours. The criteria is identical to our protocol in Barcelona, and the results are very interesting since out of these 16 donors, they have been able to obtain 29 kidneys, 8 livers, 4 pancreas, and 3 lungs. They have been finally transplanted. Out of that, they have had 4 graft losses for the kidney, 1 liver due to primary non-function, and just 1 ischemic cholangitis. So normothermic regional perfusion, either in type 2 or 3 DCD, offers the possibility to obtain good quality liver grafts from transplantation. And normothermic regional perfusion prior to extraction is essential to maintain and to select liver grafts for transplantation, evaluate potential grafts, reject potential grafts based on viability markers. Nevertheless, I continue to say that it needs to be more efficient, it needs to be more effective, and it needs to be combined with advanced forms of maintenance, ex situ. It needs to be more efficient. Well, I guess if you see the reasons why we failed to retrieve organs, one was inadequate venous return. So now we are trying to use multi-prophetic venous cannula. We probably will try to avoid the use of the reservoir, and probably the best thing to do would be to change to a centrifugal pump. We are underway with these modifications. But on the other hand, you can see that some other insignificant number of patients or potential donors were rejected because of prolonged phase, elevated transaminase levels, or poor macroscopic acids. Things that we think may be reversed are relative contraindications. If we do that, if we were able to obtain or to use these livers, we may increase the number up to 32%, which is quite a number of organs obtained. So these less than 10% base control activations, and we think that approximately 1/3 of livers were turned down based on these relative contraindications. We need to go to advanced forms of organ maintenance, since I think that less stringent acceptance criteria would be dangerous for the results. So we are moving to normothermic machine perfusion. I think this is the ideal way to go, since it maintains normal metabolism, it could extend storage time beyond current limits, and in the case of donors after cardiac arrest, death, we can regenerate ATP, we can clearance toxic metabolism, and what is most important, we are able to produce or to do viability assessment prior to implantation. We proved in the experimental setting, in a group of animals, after 90 minutes of cardiac arrest, we compared 3 different groups. In one was cold storage associated. In the other one, we included a period of normothermic regional perfusion. And in the third one, after normothermic regional perfusion, the animals were submitted to the liver was submitted to normothermic machine perfusion. By doing so, with the Barcelona model, we were able to evaluate the production of bile as well as the function, and we saw spectacular results. These have already been published, but we saw that after using the NECMO, just by using normothermic regional perfusion, after 90 minutes of cardiac arrest, we were able to achieve an 83% survival. 4 of the 5 animals survived. 5 of the 6. With respect to when we use normothermic machine perfusion, then this increased to 100%. It is clear that the use of this type of liver, that you would doubt that it's been 90 minutes under cardiac arrest, is clearly much far better from this other one that was just preserved in cold storage. I think it is time to go to the clinical setting. And now, finally, we are having a machine, a normothermic machine perfusion ex vivo, and we have entered into the consortium of the Organ Preservation of Europe, which is led by Professor Peter Friend, and where there are some UK centers, including the one from one of the co-chairs, Professor Moyesen. Mm-hmm. And this is about to start a multi-center randomized control trial to compare the efficacy of ex vivo normothermic machine perfusion with static cold storage in human liver transplantation. The centers are those in UK, one in Leuven, another in Germany, and our group in Barcelona. The machine, the design, is It's a trial design. It's a prospective and randomized trial in which any eligible donor should be submitted to randomization in order either to cold storage or to machine perfusion. The idea is to obtain experience with 260 in order to see whether the machine adds any efficacy to the retrieval. And I am finishing. This is the machine. Although it seems a little bit complicated, everything is controlled. As they say, even a surgeon is able to connect red with red, blue with blue, and yellow with yellow in order to make sure that it works on the waist. And you can see it after the start of the machine perfusion, after 10 seconds, and after 60 seconds. And they maintain there up to 8 hours. Well, it is controlled, and it's all self-control. Even the surgeon may look at it to make sure that it looks okay. And I know that the early results are going to be introduced next June in the International Liver Transplantation Society meeting, joint meeting with Alita and Likash. I know they are outstanding results, and I invite you to be there in London next June 4 to 7, because I think it's going to be a big and a very big step in organ preserving and organ retrieval from DCD. Thank you very much for your attention.